This is the GECKO meeting. It happens every Wednesday at this time. We alternate with other gastroenterological specialties, and every 7th week it's paediatrics turn, which is today. So this GECKO session is hosted by the Gastro Foundation in association with the ECHO New Mexico, and locally the Gastro Foundation hosts it. Our recordings are available on the Gastro Foundation website, and we will keep the chat open for questions, or you can unmute yourself afterwards and ask away. So with that, I want to warmly welcome Natalie, and I was just boasting about how lucky we are to have Natalie at Remihima Musa Hospital. She's a dietitian. She's been here for 12 years or so. No, 10 years or so. And she's really been instrumental in assisting us with the gastroenterology patients. So Natalie did her master's dissertation on refeeding syndrome and did a retrospective study looking at refeeding syndrome in severe acute malnutrition, which is actually very poorly described and poorly researched. So I thought it would be a very useful topic to review, and I think there's no one better than Natalie to take us through the ins and outs of refeeding syndrome, and particularly in the setting of SAM. So Natalie, if you can start sharing your screen, and then when you're ready, you can take it away. So I can see in presentation mode. Perfect. Thank you, Natalie.
Thank you so much, Tim. Thanks for the opportunity to present on this platform. Today I will be discussing, and now it's not moving. Sorry, Tim, it's not moving.
Just stop the share, Natalie, and then open up again.
Okay, I'm so sorry. Let's try it again.
Is it not moving for you?
That is so strange, and we checked it earlier on.
Okay.
It is not.
Do you want to stop the share? I can share from my side.
Okay, great. Thank you.
Do you want to go ahead?
Yes, thank you. Should I just say next slide?
Yes, please.
All right, next slide. Today I will be discussing severe acute malnutrition with a focus on refeeding syndrome, and then I'll also be discussing results of a study that we published earlier on in the year. Next slide. Acute malnutrition, also known as wasting, as we know, can occur as a result of food shortages, infections, or disease, and it is divided into our severe acute malnutrition and moderate acute malnutrition. And it is severe acute malnutrition that poses a significant public health challenge, particularly in the low and middle income countries, and accounts for more than 400,000 children deaths under the age of 5 each year. The most recent statistics that are available, just to show you how prevalent malnutrition still is in 2022, 13.7 million children suffered from severe acute malnutrition. Next slide. When we look at the definition criteria, it is based on the WHO growth standards of either a weight for length or a weight for height below the -3 standard deviations, or a mid-upper arm circumference of below 115 millimeters, or the presence of bilateral pitting edema. I've also included a criteria that was published by the new WHO guidelines at the end of 2023, And they included criteria on how to identify infants less than 6 months who are at risk of poor growth and development. And this criteria is a weight for age below -2, a weight for length below -3, and a mid-upper arm circumference below 110 millimeters from 6 weeks to 5 months, as well as failure to gain weight based on 2 consecutive measurements. The guideline that was released for the management of SAM in 2023 has a big focus on preventing severe acute malnutrition. Once a child is classified as having severe acute malnutrition, they don't necessarily have to be admitted. Only those with complicated SAM need to be admitted, and those are the patients with SAM who have more than one IMCI danger signs, any acute medical problems or conditions, the presence of severe nutritional edema or poor appetite, and weight loss in below 6 months of age. Next slide. Once these children are admitted, they require urgent care, and this includes nutritional intervention. So once these patients with complicated SAM are admitted, they put on a protocol developed by the WHO, and it is a 10-step protocol, which is divided into 2 phases. Your initial stabilization phase, which focuses on treating the life-threatening conditions. And then once appetite starts improving, this signals that one is able to transition to the rehabilitation phase, which focuses on catch-up weight and high energy and protein intervention. But literature has shown that a rapid introduction of nutrition can lead to refeeding syndrome. Next slide. If we look at the definition for refeeding syndrome, or not the definition, what is refeeding syndrome? It's a life-threatening complication which occurs after the sudden introduction of nutrition after a period of starvation, and it's characterized by severe metabolic disturbances such as your hypophosphatemia, hypokalemia, hypomagnesia, and thiamine deficiency. It was first described in World War II when concentration camp survivors, famine victims, and prisoners of war started abrupt feeding, and this led to them becoming very ill or even dying. Most of what we understand on refeeding syndrome today is based on a study which took place in the 1940s called the Minnesota Starvation Experiment. And this study was a prospective randomized controlled trial which included 34 healthy men who underwent a calorie restriction of 1,600 calories a day for 6 months, and they lost an average of 25% body weight. After the restriction was lifted after the 6 months and feeding was commenced, some participants developed severe cardiac complications. So this study undoubtedly would not pass ethical clearance today. And it is one of the few studies that have assessed the direct physiological effects of prolonged starvation and then subsequent refeeding. Most studies since then have relied on retrospective observational data and using inconsistent definitions of refeeding syndrome. Next slide. I'm going to just try and briefly discuss the pathophysiology, which I'm sure you will understand this better than I do. But to start with the state of starvation, which reduces the circulating blood glucose, And this shifts the metabolism from anabolism to catabolism, leading to a decrease in insulin and increase in glucagon and cortisol. This activates gluconeogenesis and glucogenolysis and protein catabolism to break down all the protein and carbohydrate stores to maintain normal blood glucose. It also results in a depletion of your intracellular vitamins, minerals, and electrolytes. So after a period of starvation, after one reintroduces feeds again, the sudden rise in glucose causes a rapid secretion of insulin and glucagon. And it's this high insulin, rapid insulin secretion that shifts the metabolism from catabolism to anabolism, and it causes an overwhelming shift of electrolytes to go from the extracellular spaces into the cells, and it's resulting in sodium and fluid retention in the extracellular spaces, and it's this that then causes the electrolyte imbalances, which causes the potential clinical complications. Just to mention a few: hypertension, arrhythmias, heart arrest, heart failure, respiratory failure, renal failure, convulsions, just to mention a few. Next slide. I'm mentioning this criteria of risk factors specifically for this group of gastroenterologists, because one of the main risk factors for refeeding syndrome in children identified by Marino et al. Actually includes inflammatory bowel disease. They also say that severe malnutrition with a starvation pathology is a risk factor, anorexia nervosa, your preterm infants, and your hematological cancers. Next slide. In 2020, Aspen released a consensus criteria for identifying pediatric patients for risk of refeeding, and they categorized them into a mild, moderate, and significant risk based on certain cutoffs of either your weight for length or your weight loss, energy intake, your abnormal pre-feeding electrolytes, comorbidities, and the loss of subcutaneous and muscle mass. I'm not going to go into detail with this, but this table is very nicely shows all the criteria. Next slide. So if we look at the definition of refeeding syndrome, there is still a lack of a universally accepted definition. There are, however, two consensus or hallmark signs of refeeding, and that is your hypophosphatemia and the development of the syndrome within a few days of starting feeds. In 2020, however, two consensus recommendations were published. The one was by Friedli et al., and they classified refeeding syndrome into either manifest or imminent refeeding syndrome. So manifest refeeding syndrome, they suggested to be diagnosed by a drop of phosphate by more than 30%, or to a value of below 0.6 millimole per liter, or to other electrolyte changes with clinical symptoms. And the imminent refeeding syndrome would be electrolyte imbalances only. And then Aspen also recommended a consensus definition, and they divided, or they classified refeeding syndrome into a mild, moderate, or severe refeeding syndrome based on a drop of either your serum phosphorus or potassium or magnesium by by a percentage from the baseline. So for mild, it would be a decrease in 10 to 20% of electrolytes. A moderate refeeding would be decreased by 20 to 30%, and severe refeeding would be a drop of more than 30% of your electrolytes from the baseline, together with organ dysfunction, which occurs as a result of these electrolyte imbalances. Next slide. Thank you. If one looks at the nutritional interventions for severe acute malnutrition and refeeding syndrome, you'll see that they are incongruent, and very few studies have investigated the incidence of refeeding syndrome in SAM. If we look at the table, so next slide, sorry. Thank you. If we look at this table, and we can go to, I've just summarized all the published recommendations for the treatment of refeeding syndrome in the pediatric population. And if you compare it, next slide, if you compare it to the WHO guidelines on the right-hand side, which technically hasn't really changed since 1999. And just to show how incongruent the guidelines are within refeeding as well as the refeeding compared to WHO, if you look at the Mayer and Marino, they recommend starting feeds at 60 to 75% of the daily reference values, which would work out to roughly 50 to 70 kcal per kilogram. And if you compare that to the WHO guidelines, where the stabilization phase is 100 kcal per kilogram, and this is recommended from 0 to 5 years. And if one actually looks at the daily reference values for a 1 to 3 year old, it's basically starting at 100% of the daily reference values. Next slide. So the WHO has, however, implemented guidelines to prevent refeeding syndrome. They introduced a transition phase of feeding. This was introduced also in 1999. And basically, this is the optimal approach is actually still not known, but they give guidelines on how to transition, slowly increasing energy and protein from your stabilization phase to your rehabilitation phase. This also hasn't changed since it was published. The only thing that has been added is how to transition with ready-to-use therapeutic food instead of the milk-based F75 and F100. Next slide. The WHO has also recommended monitoring for heart failure, which is basically to prevent refeeding syndrome. And they recommend that during transition phase feeding, one should monitor the pulse and respiration. And they say that if the pulse increases by 25 beats per minute or respiration by 5 breaths per minute for two successive 4-hourly readings, then one actually has to reduce the feeds to 100 mils per kilogram for a day, and then increase to 115 mils per kilogram over the next day, and then back to the initial 130 mil per kilogram for the next 48 hours. However, they do not give any guidelines on how to replace electrolytes if refeeding syndrome does occur. Next slide. I've just included this table, which Dr. De Meyer actually compiled. He adapted it from Polcini and Somers, and this is just examples of how to replace your electrolytes if refeeding syndrome does occur, and specifically these are for pediatrics. Next slide. This is just a practical example of what can be used to replace these electrolytes, also compiled by Tim. It just shows also what can be used in poor resource settings, such as some state hospitals. Like, for example, we have to replace phosphate orally with a fleet enema. Next slide. I'm now going to be discussing some results that we published in April this year based on my master's study. It was a retrospective cohort analysis of factors associated with the development of refeeding syndrome in children 0 to 59 months diagnosed with SAM in a South African setting. Next slide. The aim of this study was to determine the incidence of refeeding syndrome and to also explore whether there is any significant risk factors on admission that made these children with SAM develop refeeding syndrome. It was a retrospective cohort study at Rahima Musa Mother and Child Hospital. We described refeeding syndrome as a drop in blood phosphate levels by more than 0.16 to a value of below 0.65 after the initiation of feeds. And at the time of this data collection and study, this was at the time the most common definition used for refeeding syndrome. We then compared the biochemical, admission biochemistry, the clinical signs and complications between those patients who developed refeeding syndrome and those who did not develop refeeding syndrome. During the period of review, there were 592 children with SAM who were admitted, but only 148 files could be retrieved. And out of those files, after verifying the diagnosis of SAM, only 126 participants were included into the study. The incidence of refeeding syndrome in this study was 8.7%, 11 of the children developed refeeding syndrome. And if one looks at two other similar studies who also looked at refeeding syndrome in severe acute malnutrition, the incidence varied from 15 to 21%. But if one looks at the different definitions that were used to diagnose refeeding syndrome, they are all different. And so it's actually difficult to determine an actual incidence and even to compare it. There was no significant findings on the demographic data. Next slide. When we looked at the anthropometry and the length of hospital stay, we did see that children with who developed refeeding syndrome had a significantly longer duration of hospital stay compared to those who did not develop refeeding syndrome. Next. Next. The length of stay in those who developed refeeding syndrome were 18 days versus 12 days in the RFS negative group. The mortality rate in this study was 15.1%, and in the total group with 18.2% in the refeeding syndrome group, compared to 14.5% in the refeeding syndrome negative group. Tickle and Deno and the WHO have published that if one follows the WHO guidelines, the fatality rate should be able to be decreased to below 10%. But if one looks at research, the mortality rates in South Africa public hospitals ranges from 6.5 to 40.8%, despite following these WHO guidelines. If we look at the biochemical findings on admission, we saw a significantly the SAM patients who developed refeeding syndrome presented significantly more with hypophosphatemia, hypokalemia, and hyponatremia on admission. Next. 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 These findings, hypophosphatemia and hypokalemia, are common findings in malnourished children. One very interesting indicator, which has not yet been described at all as a risk factor for refeeding syndrome, is we found that an elevated INR on admission was significantly associated with developing refeeding syndrome. Dr. De Meyer and Salugi did a study in 2011, and they saw that having a prolonged clotting time, an INR above 1.7, conferred the highest risk of death amongst children with severe acute malnutrition. This is therefore could possibly be a very important indicator of the severity of SAM, and definitely needs more research to confirm this this finding. Next slide. The clinical signs and medical complications on admission. Patients who developed refeeding syndrome presented with significantly more diarrhea, dehydration, and the presence of urinary tract infections on admission. Next. Okay. So, diarrhea and dehydration are also common findings in severe acute malnutrition. Urinary tract infections has actually also been associated with a more severe form of malnutrition, according to Jones and Berkeley. And Mandler et al. Also found that urinary tract infections had a significant risk factor for mortality in children with SAM. So just to summarize the key findings of this study, we saw that children who developed refeeding syndrome were likely to present on admission with hypophosphatemia, hypokalemia, hyponatremia, dehydration, coagulopathy, and urinary tract infection. And they also stayed a significantly longer period of time in hospital. Next slide. The limitations of this study, we had to rely on medical records, which were very difficult to obtain, and therefore we had a very small sample size. The high mortality rate could be due to the retrieval bias, because where our records are kept, the mortality files are kept in a different section to the general patient files. And I could obtain almost all of the patients who passed away, but the general patients were very difficult to obtain. Next slide. So implications and conclusion. There's actually no way of determining the incidence of refeeding syndrome because of the lack of a standardized definition. But hopefully, since Aspen released the consensus definition in 2020, we could possibly start seeing a true, or start determining a true incident of refeeding syndrome. We know that SAM is a risk factor for refeeding syndrome, and refeeding syndrome is a life-threatening condition. We therefore need a universally accepted definition for refeeding syndrome so that we can diagnose refeeding syndrome. And then also we need more research to determine these risk factors, to possibly update the current treatment protocols and improve outcomes. Thank you. Thank you so much. Are there any questions?
Thank you so much, Natalie. I think while people think about questions and raise their hands or type in the chat, just again to say thank you for agreeing to talk to us, and really well done for trawling through hundreds of thousands of results. So I think my worry about refeeding syndrome and SAM is obviously the setting that we see SAM. It's often the laboratory services are not what they're supposed to be. And it's a toss-up between how often you do monitor blood levels and whether you at what stage you start supplementing. So I don't know if you want to comment on that, if you want to, what would be the ideal frequency of monitoring phosphate, etc., and for how long?
So the guidelines, but these guidelines are basically, like you said, they're in an ICU setting or just a better setting, but they do recommend monitoring electrolytes at the baseline and daily for the first week, which obviously in our setting definitely doesn't happen. And I also think that it's quite important to not only monitor the pulse and respiration during transition, but actually right in the beginning of feeding as well.
It's a clinical detection as well.
Yes.
So I don't see questions. So I'm going to raise another difficult point, and that's the phosphate content of feeds that we give. And you and I have been through this. But generally, the phosphate content of F75 and F100 is reasonably high, but it's not at all high in infant formula. So our practice used to be giving infant formula instead of F75 because that was more available in our hospitals. I don't know if you've got any comments on people who might still be doing that, or any caveats.
So currently we've actually we've been able to procure F75. It's only in periods that for some reason we run out of stock and the companies can't deliver, that we do use just a standard formula, and we supplement that with extra energy, and we mix it differently to meet the criteria for a starter formula. But obviously then we also have to add the recommended potassium, magnesium, and all the vitamins and electrolytes to that. But there isn't actually a recommendation for how much phosphate to be added. There's only a recommendation on the potassium and magnesium.
So there's another very important point, and I see some of our participants are from other African countries, and I'm not sure what the availability is of the mineral mix and the vitamin mix. In other countries, we don't have it accessible to us. But what we realized, and what's quite important, is that phosphate is not actually supplemented in the mineral mix. So you really need to watch when you children at risk for refeeding syndrome. So Elizabeth Tabane, talking about refeeding syndrome seen in neonates, especially after prolonged NOPA-OS in patients with necrotizing enterocolitis. You want to comment, Natalie? I can if you.
Yeah, thanks, Tim.
You're not in the neonatal wards usually. Yeah, so there's two interesting groups in neonates. The one is the patients who are on acute NOPA-OS for a prolonged time. Generally, we would be giving them intravenous fluids and maintaining some insulin secretion, but obviously we're not giving them the full amount of feeds that they need or calories that they need. The other group is children who are born with intrauterine growth restrictions. So they've actually been malnourished in utero. And during the first week of life, when they get fed, they develop refeeding syndrome. So not so much the PREMs, but actually the ones with intrauterine growth retardation can also get problems, especially with phosphate. Juliana wants to clarify the point on the use of fleet enema, I guess. So I can also, so it's again a local thing that we struggle to get hold of phosphate preparations. And the highest phosphate containing thing that we have is fleet enema, which is used for rectal irrigation and disimpaction. And I think Natalie put the numbers up on the screen as to how much it contains. Any source of phosphate, if you give it orally, is going to put the child at risk for diarrhea. So, and that includes if you in your rectal enemas orally, just something to be aware of. Natalie, do you want to add?
No, that's fine. Thank you.
We're looking for other questions or hands. Let's see. So if that was the questions, I'm going to once again thank Natalie very much for agreeing to talk to us about refeeding syndrome. I hope it's raising some awareness for refeeding syndrome and to assist in thinking about refeeding syndrome when you have a child with any risk factors, any form of starvation or malnutrition who then gets refed. And so thank you. I also want to thank iEcho New Mexico and iEcho India, who does the technical side of things. As I mentioned, all our recordings are available on the Gastro website, the Gastro Foundation website, if you want to have a look. Thank you to the Gastro Foundation, obviously, and thank you to the sponsors. Our session next week will be on patient blood management, so we hope to see you all there. Thank you, Natalie.
Thank you
Thanks,
so
everyone.
much, Tim, and thank you, everyone.
Thanks,
Have a
bye.
lovely day. Bye.